Absolute liberty is the absence of restraint. Responsibility is restraint. Therefore, the ideally free individual is responsible to himself. Henry Adams. Research suggests that restraint use in the elderly should be avoided because of poor physical and psychological outcomes, as well as an increased risk for death. First, we'll define physical and chemical restraints and list why these restraints are used. Secondly, we'll discuss what physical and psychological effects these restraints may have. What are physical restraints? The Center for Medicaid and State, CMS, in 2008 defined a physical restraint as any manual, method, or physical or mechanical device, material, or equipment that is placed on or adjacent to the resident's body that the individual cannot remove easily, which restricts freedom of movement or normal access to one's body. Common physical restraints used include posy vests, soft limb restraints, mittens, sad rails, and lap belts on a wheelchair. Chemical restraints have been defined as any medication given primarily to control a person's behavior. The medication is not to treat a mental illness or physical condition. Dr. Lambeth in the Mental Health Act of 2013. Medications used as chemical restraints include benzodiazepines like lorazepam, risperidone, Haldol, and midazolam. Chemical and physical restraints are used for a variety of reasons. Safety for the patient or the healthcare worker, integrity of lines and tubings, integrity of wound dressings, convenience, family request, and to prevent falls. But CMS said in 2007 that falls do not constitute self-injurious behavior or warrant the use of restraints. Although restraints have traditionally been used as a fall prevention method, they have major serious drawbacks and can contribute to serious injury. There is no evidence that the use of physical restraints, not limited to but includes sad rails, can reduce or prevent falls. So I have listed behind in my visual aid some pictures of the common restraints, including mittens. And then on either side, I have the poor outcomes, physical and psychological, that occur from restraint use with the elderly. First, let's discuss the physical effects. Elderly patients can experience urinary incontinence, dehydration, malnutrition, immobility that can lead to bed sores, muscle contractures, loss of muscle tone and muscle function, more wounds, strangulation, and even death. In 1992, the Department of Health and Human Services concluded that at least 100 deaths or injuries annually are related to the use of restraints. Many of these deaths occur when the patient is trying to get out of the restraint or while attempting a purposeful behavior, such as going to the bathroom. Psychological effects are detrimental to the elderly as well. They have reported feelings of loss of respect, loss of shame, depression, self-isolation. There are reported incidents of increased agitation and aggression, hallucinations, nightmares, insomnia. Elderly report a decreased quality in life from having been restrained. A study done by researchers Inyal and Charpenter in 1996 revealed that restraints actually increase the risk for delirium fourfold. Other outcomes associated, even not physical and psychological, in the elderly are increased length of hospital stay and increased hospital cost. In May of 2011, the Inspector General of the Department of Health and Human Services concluded that approximately 305,000 elderly nursing home patients, 14%, who received an atypical antipsychotic drug from January 1st to June 30th of 2007 was at a cost of hundreds of millions of dollars. Chemical and physical restraints are commonly used in the elderly population. They're used for safety, convenience, and fall prevention. Research suggests that these restraints should be avoided in the elderly because of poor physical and psychological outcomes and heightened risk of death. CMS in 2008 in the Nursing Home Reform Act mandates the resident has the right to be free from any chemical or physical restraint that's imposed for purposes of discipline or convenience and is not required to treat the resident's medical symptom. Poor outcomes are associated from the restraint use in the elderly. The use of restraints needs to be the exception, not the rule.